All right. Hi, everybody. Thanks for being here today. I'm excited to share some data from a project that I've been working on with some other folks who are here today, here at this conference. So Dr. Ann Nederveld, who's also at the University of Colorado in the Department of Family Medicine. And then Catherine Jans, also, I think she had to leave, unfortunately, but she's with Health Begins and has also been here. So excited to share this out with you all. Also a little nervous. Some of this work is pretty exploratory, and so we really welcome your feedback afterwards. Emails listed at the end. Truly would love to hear your thoughts on the framing, the takeaways, all of it. So this project aimed to understand healthcare staff and clinician attitudes about food insecurity. And we think that attitudes matter because healthcare workers' attitudes likely impact their ability to screen and refer in ways that are non-stigmatizing and that are empathetic. And additionally, attitudes influence how much organizational resources go into things like screening and referral and addressing food insecurity in contexts where organizations are addressing a lot of competing priorities. And then additionally, as you all know, advocacy is one of the 5 A's in the National Academy's framework, and we know that healthcare organizations have the potential to play a powerful role in advocating for policies that could improve food insecurity, especially at the local level. So understanding attitudes is a key first step towards understanding what the possibilities for that advocacy might look like. The story of how this survey came about starts with the Accountable Health Communities Initiative. So Western Colorado was a demonstration site, and food insecurity was identified as the most prevalent need in Western Colorado. So in 2021, to encourage healthcare organizations to better identify food insecurity and assist food insecure patients, one of the AHC community bridge organizations in this region decided to develop a training for healthcare workers. And they reached out to us to see if we could conduct a survey to inform that training. And specifically, they were interested in having us look at food insecurity-related knowledge, attitudes, which is what this presentation focuses on, as well as experiences. And stigma is one of the key concepts that we wanted to explore through this survey, and that's because we know that it's a barrier to health sector efforts to identify and address food insecurity, and because our previous qualitative work on this topic had identified some prevalent harmful narratives that perpetuate stigma. And so those narratives that I'm going to be talking a lot about are this concept that individuals experiencing hardship are responsible for causing their own challenges, and the concept that people who don't really need the help often exploit and misuse assistance programs. And so, like I said, these were narratives that we'd heard over and over again in qualitative work that we'd done in this topic in this area. And so we really wanted to use this survey to try to assess the extent to which the perspectives of healthcare workers aligned with these stigmatizing narratives. So we did this work in Western Colorado. As you can see, it's far from Denver. The part in the middle is mountainy. The part to the west is deserty. All of it is pretty politically conservative. Our partners included Rocky Mountain Health Plans, which was the regional Medicaid administrator for the region, and then the Southwestern Colorado Area Health Education Center. And this was the AHC Community Bridge organization that was planning the training that we collaborated with to conduct this survey. And then we, when I say we, I mean Ann and I, and then our other teammate Liz, we are Partners Engaged in Achieving Change in Health, or PEACHNet, and we are a practice-based research network focused on Western Colorado specifically. We're based in the University of Colorado Department of Family Medicine. So Southwestern Colorado AHEC conceptualized the survey, and then we developed the questions based on previous work that we had done on this topic, so that previous qualitative work, as well as some surveys that we had conducted previously with healthcare clinicians and staff. Our partners distributed the survey through a snowball approach. So they sent the link to their primary contacts at 61 different organizations, and then they asked those contacts to send the link to other clinicians and staff within their organization, and all responses were anonymous. We first conducted descriptive and bivariate analyses of all data, and then we conducted a confirmatory factor analysis and used structural equation modeling to look at the look at latent constructs related to the stigmatizing narratives that we'd previously identified. And so just a quick note on terminology, a latent construct is something that we can't directly observe or directly measure, but that we can indirectly measure by using multiple indicators that are thought to tap into different aspects of that construct. So an example is anxiety or depression or self-confidence. These constructs where you can't measure it with a ruler or give a specific number, but by asking a bunch of different questions, we can understand to what extent is maybe one person experiencing anxiety to a greater degree than another person. And then confirmatory factor analysis is a way of looking at how do items in your survey, how do your questions tap into that latent construct of interest. And structural equation modeling is looking at how do latent constructs relate to each other and to other factors that we may be interested in. And so again, the latent constructs that we were really interested in here was the attribution of food insecurity to individual causes and the belief that assistance programs are exploited. So that's what we were trying to measure. And we received 347 responses in total. We unfortunately can't calculate the overall response rate because of that snowball distribution approach that I mentioned. We also noticed that there was an increase in data missingness towards the end of the survey, and this is due to respondent drop-off, which unfortunately is pretty common with this type of survey. But if you see the ends, the overall numbers that I mentioned at the top, for some of the results, that's why they're changing a little bit across different items in the survey. So the table on the left shows the respondent breakdown by role and facility type. And we used broad role categories that were based on the Bureau of Labor Statistics standard occupational classification system. And so the healthcare practitioner category included physicians and other clinicians, but then also roles like pharmacy and lab technicians and paramedics. And then the healthcare support workers category included clinical staff like MAs, CNAs, certified nursing assistants, as well as non-clinical patient services staff like front desk staff. And then the healthcare operations category included all other types of staff and administrators who did not provide direct patient care or didn't have direct patient interaction. The main thing to note in the table on the right is that the demographics of our survey respondents broadly reflect the demographics of the Western Colorado workforce, healthcare workforce in general. So in terms of being primarily female, and then around a 10th Hispanic or Latino. So these results, these showed the results related to food insecurity prevalence. So overall, 18% of our respondents reported current food insecurity, and nearly half of respondents reported having experienced food insecurity at some point in the past. Both current and past food insecurity were highest among the healthcare support workers, and this makes sense given that that group included roles that tend to be lower paid, like MAs and front desk staff. And then this is the breakdown of responses to a question about how familiar respondents were with various food assistance programs. So the type of programs that respondents tended to be the most familiar with were food banks, and then they tended to be the least familiar with the SNAP program. And overall, you can see that the majority of respondents were only a little bit familiar with across all of the programs that we listed. So this slide shows how respondents answered questions about perceived causes of food insecurity. And to be very clear, the perceived causes that are shown here that we asked about, these are not based on empirical data. These are not based on the opinions of our research team. These are based on opinions that we heard in qualitative interviews that we had done previously in this region on this topic. So for these questions, we listed a variety of causes shown here, as well as some additional ones, some of which placed the responsibility on the individual, and some of which described structural factors outside of individual control. And so in the actual survey, this list of causes was all mixed up, and we didn't have it labeled in terms of individual versus structural causes. And so we had this list, and we asked respondents to indicate for each cause listed whether they thought that it contributes a lot, a little bit, or not at all to food insecurity. And we found it very interesting that respondents tended to endorse both structural causes and individual causes at high rates. So for example, over 90% of respondents thought that the high cost of food contributed at least a little bit to food insecurity, But at the same time, over 80% thought that people not wanting to work also contributed a lot or a little bit to food insecurity. So broadly, you can see that while our respondents recognized the structural causes of food insecurity, they also tended to endorse this stigmatizing narrative that food insecurity is attributable to personal failings. This slide shows the extent to which our respondents thought that people in their community exploit food assistance programs by using them when they don't really need them. And again, to be clear, studies that have been done on SNAP and WIC indicate that actual cases of fraud and program misuse are extremely rare. So we don't have that data across all programs. The data that we do have suggests that program exploitation is actually extremely uncommon. But like I mentioned at the beginning, one of the stigmatizing narratives around use of food assistance programs is this idea that people are gaming the system by using them when they don't really need them. And you can see that narrative playing out here, where over half of our respondents thought that at least some people are using food banks when they don't really need them. And I think, just to comment on something that's come up in other presentations, the fact that often an objection to uptake of assistance services is this idea that other people out there need it more than I do. And I think there's a relationship here. I think there's a relationship between this idea that there's people out there misusing services and a desire to distance oneself from that and not to be that, and that may increase the tendency of this idea that I don't want to use something that somebody else might need. So just noting a relationship that I think may be there. This diagram shows our confirmatory factor analysis results. So what this shows is our two latent constructs. This. Our two latent constructs in the circles in the middle, and this font got a little messed up, I think. And then below, these are the survey items that we use to measure each of these latent constructs. And then what this curved arrow at the top shows is that there was a significant correlation between these latent constructs. So overall, what these results tell us is that our data supports the idea that perceiving assistance program exploitation and attributing food insecurity to individual causes are different but related aspects of stigma. And these are our structural equation modeling results that show the relationship between our latent constructs and covariates of interest. So what this shows is that respondent age was significantly associated with attributing food insecurity to individual causes. So this meant that the older that an individual was, the more likely they were to endorse the concept that food insecurity was due to individual causes. And then familiarity with food assistance programs was negatively correlated, so inversely correlated with perceived assistance program exploitation. So basically this meant that the more familiar somebody was with food assistance programs, the less likely they were to think that other people were exploiting them. So this is all pretty complex, and we obviously need to do further work to really understand what we're seeing here. But what we do think these findings help us to start understanding I think they help us to start understanding and unpacking stigma around food insecurity and to start thinking about how we might go about trying to address stigma among healthcare workers. So for example, these findings suggest that increasing familiarity with assistance programs could be a place to start in terms of reducing this stigmatizing perspective that people frequently exploit these programs. So like I mentioned, we unfortunately can't calculate the overall response rate or response frequencies by organization due to our snowball distribution approach. And we didn't use a representative sampling approach that would allow this to be broadly generalizable to the region. And we also had limited respondent characteristic data, which means that we can't examine the influence of job role or socioeconomic status. But we do think these findings still have some important takeaways and implications. So first, just that nearly 1/5 of our respondents were food insecure. And second, that many respondents held perceptions that contribute to stigma. What this means is that many healthcare workers in this population may both be biased against individuals with food insecurity and harbor misinformation about assistance programs and be experienced with food insecurity themselves. We think these findings raise questions about how to ensure that healthcare workers can address food insecurity in a destigmatizing manner. They raise questions about how to ensure these workers are themselves earning a living wage, and about the healthcare sector's role in advocacy. And so we think there's a need for further study of poverty and of anti-poverty bias among rural healthcare workers, and how these may impact healthcare sector strategies to address health-related social needs. All right, thank you.